Fab, good evening, everyone. I'm just looking for a quick sound check, make sure everyone can hear me. Just someone throw a yes in the chat, that'd be brilliant. Brilliant, fantastic. Thank you very much indeed for that. Yes, absolutely. You can record the screen. We are recording it as well, and it will be uploaded to YouTube either tomorrow or the next day. It depends how long it takes for everything to upload. So yes, there will be recordings made available. I'll post a link in the Facebook group. So welcome along, ladies and gentlemen. We're going to make a start a little bit early because I can see that we've been full for quite a while now. So unfortunately, the way Zoom pricing works, and unless we charge for these webinars, there's no way of increasing the capacity more than 100. So unfortunately, it's first come, first serve. So welcome to the 100 of you that have joined us. Lovely to see so many of you. It's great to have a nice full webinar. So bear with me a second. Okay, unfortunately the phones are going a bit mad now with people that can't get in. So okay, fine. Let me just close down the chat. So welcome, a little bit early, but welcome along. Thank you for joining us here at STC Training Solutions. It's great to see so many of you, and I did have a quick look through the guest list. We've had some familiar faces, which is brilliant. So welcome back. These aren't the first webinar series we've done. So those of you that have watched the previous ones, we've done an ECG webinar series on ECGs back last beginning of lockdown. It's been a bit of a lockdown thing, hasn't it? So we started those beginning of last year, and they are available to watch on YouTube. And no doubt at some stage we will refresh those, the content of those, and hold them live again. Then we did some work which helped people going through the FRET4 pathway, so that's about to be re-uploaded by the looks of things. So hopefully we can get that reposted up to YouTube for anyone that's FRET inclined and wanted to go through the FRET pathway. There was some assistance videos there. And then we got thinking about what we're going to do next. We toyed with a few ideas, and actually I thought, you know what, I'm a paramedic that works in primary care. I have done for a year now, and I wish there was something like this available to me when I kind of joined primary care. I think what we're aiming at here is looking at some subjects that are really kind of common type things that as a paramedic coming off the road into primary care, types of subjects and presentations and illnesses and chronic disease management, etc., that would be expected to be fairly competent in. And as I say, lots of things I wish I'd known when I joined, and lots of steep learning curves. So I'm hoping to share those with you over this kind of series. It's going to be quite a long series. We're starting to put together the kind of long list of what we're going to be covering, but we're going to start with some cardiovascular presentations. So tonight, hypertension, which arguably is probably one of the most common things that I deal with day to day. Again, relatively simple once you understand the kind of nice guidelines and what's actually going on with the medication you're using. Then we're going to look at things like heart failure, a little bit more complex. We'll be looking at some cardiac issue management, so some atrial fibrillation management, and we're going to be looking at a couple of other bits and pieces. We're starting to put a bit of a schedule up on the website, so keep an eye if there's a subject that particularly interests you. And likewise, if there's anything you want us to cover that we haven't covered or you can't see advertised, then please do drop us an email at webinars@stctrainingsolutions.co.uk, and we'll do our best to get that covered in one of the upcoming webinars. So we'll get going. So a little bit about me and us. So STC Training Solutions was founded a couple of years ago now, and we started by teaching first aid courses. We then branched into the FRET pathway. So we've been a FRET provider for just under a year now, delivering FRET3 for safe administration, life-saving meds, and the ILS courses. We've always kind of wanted to branch out into other areas of pre-hospital care, and particularly looking at doing CPD events like these for registered healthcare professionals, like a lot of yourselves, and this seemed like a great place to start that. So and it's been hugely popular, so I've been kind of really amazed by the amount of interest in this webinar. So that's really positive. So thank you very much for everyone that's been sharing these events and liking them and following us on Facebook, etc. So if you haven't already, do give us a like on Facebook. It's the easiest way of keeping up to date with the latest webinars, and of course sometimes the schedules do have to change. We're all working full time, so do keep an eye on our Facebook page. We'll announce any changes to the schedule there first, and obviously through our website as well. So I'm a paramedic by trade. I started in the London Ambulance Service, and as I say, around this time last year I left full time to go and work for a GP surgery. in East Berkshire. And from there, my plans are to become an advanced clinical practitioner and do independent prescribing, which is very much on the cards for later this year. But as I say, this series is more about the types of things that are going to be useful for those of you switching or making the change, thinking about making the change, wondering whether it's for you. And of course, those of you that have no intention of leaving the road and just want to kind of brush up on some of the primary care type knowledge that we kind of build up fairly quickly once we're actually in that industry. So that's it. I'm by no means an expert in primary care, so don't take that impression. But as I say, if there's anything I can answer, then please do throw it in the chat, and I will do my best to do that. So let me just check the chat. So fantastic, great stuff. So onwards and upwards. This is an interactive webinar, so do pop questions into the chat box. I'll keep an eye on that. So if there are any natural kind of pauses in the proceedings, then I'll go through the list and have a little look and see if there's any questions I can answer. So don't worry if you ask a question and I go on and answer it. It's not a problem, but do throw questions in there. STC admin are in the chat. If you are having any technical issues, they should be able to sort you out. So even after the event finishes tonight, do feel free to tweet, email, or WhatsApp us if you have any questions. Details are on the screen at the moment. Webinars at stctrainingsolutions.co.uk is a dedicated box for anything to do with the clinical CPD. Now, we are going to use Mentimeter tonight towards the end. So those of you that haven't used Mentimeter, go to menti.com. You'll get a code when we get to the appropriate slide, and you can vote in our quiz. So there's a little end of course quiz just to see how much has made sense. And of course, there will be CPD certificates available at the end tonight. We're doing something new. We're going to use Medal to do our certificates tonight. So Charlotte, who's STC admin, is going to pop a link to that at the end. So you do just need to leave us some feedback, and then you'll get a downloadable PDF certificate for your portfolio. So tonight should last about an hour. So if everyone's comfortable, we'll get going. So session plan tonight, we're going to look at how the body regulates, but what blood pressure is in the first place, and how does the body regulate it, the pathophysiology of hypertension, the kind of common types of causes that you might be expected to, or you might expect to see in your patient group. So diagnosis, how do we actually go about calling somebody hypertensive, and the various stages and initial things to look out for. We're going to look at some red flags and some things we don't want to miss, and some reasons potentially to refer into secondary care. Very much going to look at the NICE guidelines around first, second and third stage management. Fourth stage management, the jury's out a little bit on what's best to do sometimes. We will look by no means at biocellular level, but we will be looking at the pharmacodynamics of the common blood pressure medications, just so we've got an understanding when we're starting these patients on those meds. Those of you that are independent prescribers or planning to be, then this may well help towards your coursework for that. And then, of course, as I've mentioned already, red flags and a little bit about when we're going to potentially refer these patients into secondary care. So the general kind of overarching principle of primary care is that we try not to send too much into our colleagues in secondary care. We try and deal with as much as we possibly can in the community, but of course there will always be those patient groups that require specialist input, and it's knowing when it's appropriate to put that in place. So a little bit of basic overview. So how the heart interacts with the systemic circulation and how blood pressure kind of comes about. Blood pressure is quite clearly the pressure of the blood being exerted on the blood vessel walls, predominantly the arteries. We measure blood pressure in the major arteries, normally in the brachial artery, don't we? So it should be no surprise then that deoxygenated blood only kind of really is dealt with by the right-hand side of the heart. That pumps blood from the right ventricle up to the lungs to be oxygenated and back into the left atrium. From the left ventricle, we go into systemic circulation via the aortic arch, don't we, and all the arteries that involves. So you'll hear some terms tonight. We will go through it in a minute. Systemic vascular resistance being one factor of blood pressure, and that's largely dealt with in this area here on this diagram to the right. So the arterioles, so the smooth muscle of the arterioles is kind of where the body exerts most of its force or most of its control over blood pressure in the acute phase. So blood pressure is, of course, a function of cardiac output. Cardiac output is going to be heart rate and stroke volume. which we'll look at in a bit more detail in just a second. And obviously the more blood that flows out of the heart, whether it be at a faster rate or with increased stroke volume, if it meets the same resistance, if you increase the flow, you're going to increase the pressure. Likewise, if you increase the resistance for the same flow, you're going to increase the pressure likewise. So hopefully nothing new in that section, but we will just look at what actually functionally makes up blood pressure, so we can start to get a bit of an idea of how we're going to control it. So blood pressure is the sum of cardiac output and systemic vascular resistance, I've just said. So generally speaking, when we think about controlling somebody's systolic blood pressure, we want to affect their cardiac output. And if we want to affect somebody's diastolic blood pressure, then we want to look at lowering their systemic vascular resistance. So what do we mean by systolic and diastolic? Just for a bit of refresher. So systolic is obviously the pressure within the main arteries during systole, during left ventricular contraction, with blood being ejected into the aorta and the main arteries. That is systolic blood pressure. It's the pressure being exerted at the height of left ventricular systole. The diastolic blood pressure is, of course, the lowest blood pressure recorded during diastole. So when there is no ventricular contraction going on and the ventricles are relaxing and refilling through the atria. That is the lowest pressure recorded during that point is your diastolic blood pressure. So clearly, it goes without saying, if blood is kind of pooling within the arteries because systemic vascular resistance is high, that is going to cause a higher diastolic blood pressure. And likewise, if you, as we've said already, if you increase stroke volume or heart rate or combination of both for the same systemic vascular resistance, you're going to increase cardiac output and therefore systolic blood pressure, which should make sense. So some terms here then. So what affects cardiac output? So stroke volume times heart rate. Okay, heart rate can be controlled by the nervous system. Stroke volume has some other controls going on. So stroke volume is a function of three things. It's preload. Preload is the end diastolic volume, so the amount of blood that is in the ventricle. Predominantly, we're talking about the left ventricle here for systemic blood pressure. So the volume of blood within the left ventricle at end diastole. So when that ventricle is filled and ready to contract. So Starling's law says that if you overfill the right ventricle, then you're going to have a far greater ejection. So if we're allowing a lot of blood to flow back to the heart, then of course we are going to increase our systolic blood pressure, which of course is beneficial in sometimes, but then when it becomes pathological, we look for ways to restrict that, don't we? So the quantity of blood volume is going to affect your preload. Obviously, if you have more blood circulating because you're hypervolemic, then of course you are going to have a greater end diastolic volume and therefore preload, stroke volume, cardiac output, and systolic blood pressure. The other thing that affects preload is venomotor tone, so particularly within the lower limbs, isn't it, returning blood pressure. If venomotor tone is high, then blood is effectively squeezed back towards the heart, therefore increasing end diastolic volume and all of the above. So afterload is a function of systemic vascular resistance. So we can see that is arguably the most important area to control because it affects both diastole and systole. So it appears on both lists. So systemic vascular resistance is if you reduce that, you're going to reduce both your systolic and diastolic blood pressures, which, as you'll see later, is one of the main controls over blood pressure. And then contractility, which is the ability of the myocytes to contract. That's largely controlled by electrolytes, predominantly calcium. So reducing contractility, reducing the ability of the myocytes to contract is going to reduce the effectiveness of the left ventricular ejection. Of course, you then have pathological poor contractility and heart failure, which we're going to talk about next week. But it is a method of controlling blood pressure with some calcium channel blockers by reducing contractility. Good. So that is the function. That is ultimately the maths behind blood pressure and where it comes from, and it should start to give you some ideas of how we then go about controlling it. So how does the body control blood pressure when we're well? What's the normal kind of method of controlling our blood pressure? So there's two functions. We have the acute functions of the the central nervous system. So CNS control is going to be very kind of acute phase, very, very quick reaction. And of course we want that, we need that. If we stand up, we want our blood pressure to come with us. We don't want the blood pressure to stay on the seat. because then we come back to the C. So we want blood pressure to follow what we're doing. Obviously, if we suddenly have to sprint, then we want our blood pressure to be able to cope with that, etc. So that's obviously a function of the sympathetic and parasympathetic nervous systems, isn't it? So how does that come about? Just a bit of refresh here, hopefully. So blood pressure is measured predominantly in the carotid sinuses and the aortic arch. So from the carotid sinuses via the ipsilateral hypoglossal nerve, that's no, it's the glossopharyngeal nerve. Sorry, wrong one. So from the glossopharyngeal nerve on that side of the body, that reports back to the cardiovascular center within the medulla oblongata. So and similarly from the aortic sinus, we send signals along the vagus nerve back to the same cardiomotor center. Okay. So, so once those signals are interpreted by the cardiac centers within the medulla, we then make a decision on whether we need to increase or decrease blood pressure. And we do that through sympathetic and parasympathetic tone. When we talk about increasing blood pressure, we're talking about hypertension tonight. Obviously, decreasing blood pressure is just the opposite. We're going to use parasympathetic nervous system to reduce systemic vascular contractions, so smooth muscle contraction of the systemic vasculature. And we're also going to use that to reduce heart rate and contractility by parasympathetic nerves to the SA node and the myocytes. So when we're talking about raising blood pressure, we're talking about hypertension tonight. We do that through the sympathetic nervous system, obviously living through the thoracolumbar areas of the spinal cord. Now they do two things. So we're going to look one they specifically act on the smooth muscle, particularly within the arterioles. I said this area on this diagram at the bottom here, this area of arterioles coming off the main arteries. These are predominantly where the body likes to control its blood pressure. By increasing vasomotor tone within these areas, you can increase systemic vascular resistance quite effectively and quite rapidly. So predominantly the sympathetic nervous system is affecting these systemic vascular areas, arterial areas. But of course, we also have a sympathetic nerve fiber or group of fibers running to the juxtaglomerular apparatus within the kidney. So this hopefully is familiar to most people within the kidney. This is the nephron. This is the anatomical structure of the nephron. This is the juxtaglomerulus, the glomerulus, and the juxtaglomerular apparatus are around this area with the afferent and efferent arterioles that supply that glomerulus. And it's within this area that the juxtaglomerular cells live, and they react to reducing blood pressure. There's three things that they react to. And they produce something called renin, which we're going to come on to in a minute. But actually, one of the triggers to produce renin comes from the sympathetic nervous system. So by baroreceptors in our carotid sinuses and our aortic sinuses communicating back to the medulla oblongata, we can start producing renin on an acute phase through the juxtaglomerular apparatus, through the nervous system. So that is one of the triggers to generate renin. So what is renin and how does it fit into the big picture? So hopefully, the RAS control of blood pressure is not something completely new. Renin, angiotensin, aldosterone system. We're going to look at that, how that works now. This is obviously the very much the day-to-day management of our blood pressure, and certainly it's this process generally that's gone wrong when people are diagnosed with essential hypertension. It's something that set the monitoring of this system has gone out a little bit, and it's within this RAS system that we exhibit our control as clinicians and prescribers in reducing a patient's blood pressure. So renin, we've said, is produced by the juxtaglomerular cells in the nephron. So we've said there's three triggers to renin being released, and one of them we've already discussed is this middle one here, which is sympathetic nervous system. So sympathetic fibers neighboring the juxtaglomerular cells can excite them and get them to produce renin. Okay. Two other ways. So the juxtaglomerular cells themselves can decide to produce renin. They do so because they can monitor blood pressure. They surround particularly the afferent arterioles of the glomerulus. And they can sense blood pressure in that area, normally by kind of flow rates and things like that going past. And if they detect that blood flow is low, they deduce that blood pressure may be low, and they produce renin, which we'll see how renin starts a bit of a cascade of hormones and starts the kind of systemic raise of blood pressure. Good. So, and the third thing is the macular denser cells. The macular denser cells are a group of cells that generally line the distal convoluted tubule of the nephron, and they react to low levels of sodium within the within the nephron itself. Okay, and in doing so, they send a message through chemical receptors to the juxtaglomerular cells to produce renin also. So 3 triggers to produce renin: juxtaglomerular cells themselves, deducing that blood pressure is low; sympathetic nervous system fibers telling them to do so because they've, from the baroreceptors, they've realized that blood pressure is low; and the macular denser cells sensing hyponatremia relatively within the filtrate and asking the juxtaglomerular cells to produce renin. So why is renin so important, and what does it do? So renin interacts with angiotensin, angiotensinogen. Angiotensinogen is constantly produced by the liver. It's a hormone that's produced by the liver, and in itself is a bit of a sleepy soul. You know, it's not doing much. It's if you imagine it as a person, it's sleepwalking around the body. It's not an active. It's not an active agent in its true form, angiotensinogen. So what renin does is it comes along and it slices off the ogen off the end. It literally slices off a bit of the angiotensinogen and makes it angiotensin 1. So that's a slightly more active molecule. That's a slightly more active hormone. It does have some functions, but less related to blood pressure. So angiotensin 1 in circulation isn't doing much to raise our blood pressure. What it needs is to meet angiotensin converting enzyme ACE. It needs to meet some ACE to become angiotensin 2. Now, angiotensin 2 is the very active hormone within this cascade, and it's angiotensin 2 that triggers a lot more processes which make blood pressure rise, which is obviously what the whole process is. The body's very clever and it uses these clever feedback mechanisms. So we're going to excite renin, and we are going to. Oops, sorry, I'm getting a notification. My internet connection's not brilliant, so I do apologise if I'm dropping out for anyone. So we're going to cause renin production with the hope of raising our blood pressure. So renin is going to convert angiotensinogen into angiotensin 1. Angiotensin 1 is then going to be able to meet with angiotensin converting enzyme and become angiotensin 2, which is its active form, or its most active form. So hopefully some of you are starting to put together where ACE inhibitors then come in, which we'll talk about a little bit later. So what's angiotensin 2 going to do? It doesn't just raise the blood pressure by itself, although it does have an aspect. So it increases sodium reabsorption in the proximal convoluted tubule of the nephron. So it's going to do that by increasing the sodium potassium pump action. It's going to put channels in, etc. So if we increase reabsorption of sodium, we increase reabsorption of water. If we increase reabsorption of water through osmosis, then of course we're going to increase our volume. And if you remember that one of the slides back was if we increase our blood volume, we're going to increase our end diastolic volume and thus our systolic blood pressure, through a little complex chain there. But angiotensin 2 doesn't just do that, but angiotensin 2 does work directly on the proximal convoluted tubule itself. It actually stimulates a couple of other processes to happen to help it. So angiotensin 2 travels up to the posterior pituitary gland up here in the brain, and that secretes, or that it excites it to secrete antidiuretic hormone. So antidiuretic hormones you see over here works down in the collecting ducts of the nephron, or the collecting duct. To increase water reabsorption. It does so, but the collecting ducts are not normally permeable to water, so it puts water channels in through a very clever process. But again, increasing water reabsorption within the peritubular capillaries there is going to increase our blood volume and our end diastolic volume in the same way as sodium reabsorption is going to do. And then of course we have some more sodium reabsorption here, which comes from aldosterone. Now aldosterone is very active. It's secreted by the adrenal cortexes, and angiotensin 2 binds at the adrenal cortex at angiotensin receptors, and it starts to cause release of aldosterone. Aldosterone works predominantly on the kidney. It is also a vasoconstrictor, as is angiotensin 2. Angiotensin 2 causes vasoconstriction itself. Aldosterone also causes vasoconstriction, but aldosterone heads to the kidney and it works on the distal convoluted tubule and the early collecting ducts, and increase sodium reabsorption through the same pathways that angiotensin 2 does within the proximal nephron. Hopefully that's making sense. So fantastic. So that is RAS in a nutshell. Renin secreted by the juxtaglomerular cells through 3 different causes. So by them sensing low blood pressure, by hyponatremia within the tubules, and also by sympathetic nervous system input. Okay, good. And the net result is more sodium being reabsorbed within the nephron. Good, because that causes osmosis. And in the place where we can't get osmosis because it's not permeable to water, we put water channels in. Okay, fantastic. So, fine. Excellent. So that's the 3, and then of course we also have the we have vasoconstriction from aldosterone and angiotensin 2. Vasoconstriction we know increases systemic vascular resistance and puts up diastolic blood pressure. So this is an effective system. Okay, but when obviously when the triggers to release renin are set too high, we end up with hypertension, or set too low. Sorry, should I say. So you may have come across the term. So that's kind of what hypertension, how hypertension comes about, how blood pressure is normally controlled within the body. You may come across these terms of primary and secondary hypertension, which was relatively new to me when I came across primary care. Effectively, primary hypertension is what we also call essential hypertension, and effectively is no identifiable secondary cause. Fine. So we need to know what some of the secondary causes are. Glomerular nephritis or I can never say this word, coarctation of the aorta. So that's narrowing of the aorta, of course, is going to increase your systemic vascular resistance. It's most likely going to happen in young patients. That's going to get diagnosed at a relatively young age. Glomerular nephritis in your younger patients, so any kind of infection affecting the glomerulus or the nephron, is going to potentially cause acute phase hypertension, and that's a secondary type of hypertension. The idea with secondary hypertension, if you can identify the underlying cause and remove it, the patient will no longer be hypertensive, and that's the treatment aim, as opposed to essential hypertension, where we're looking to just bring it back down to normal limits. So secondary hypertension is rare. I think, depending on which book you read, 10 to 20% of patients. I mean, 20% I think is an overestimation. It seems fairly rare within practice for secondary hypertension. So, but we are obviously going to be looking at these causes. So I'll pop them up. These are some of them. It's worth having these in the back of your mind or on a list somewhere where you can just refer to from time to time. If you're looking at somebody that's hypertensive, particularly if they've got this, what we class as malignant hypertension, where they've suddenly become very hypertensive, definitely look for secondary causes, particularly if they're young and otherwise fit and healthy. Do they have some renal artery stenosis? Probably not going to be so fit and healthy if they've got that, but you're listening for BRUI, rapid creatinine increase with ACE inhibitors and angiotensin receptor blockers. We'll talk about that later, kind of renal monitoring. That's why one of the reasons why we do renal monitoring after we start somebody on an ACE or an ARB. If we're looking for rapid creatinine increase, could indicate renal artery stenosis. So renal disease in all its many forms. So raised creatinine, raised urine, ACR. So albumin creatinine ratio within the urine. If albumin is high in relation to creatinine, then we are potentially looking at structural damage within the kidney. So that could be causing secondary hypertension through other kind of pathways. So primary aldosteronism. So if you're producing too much aldosterone, so we've seen from the RAS system, if you produce aldosterone, you're going to get systemic vascular, you're going to get a rise in systemic vascular resistance. And of course, you're going to get sodium reuptake in the late distal convoluted tubules and the collecting ducts. So you're going to have a net effect of hypertension in primary aldosteronism. You're also looking for relative hypokalemia, because one of the triggers and one of the net side effects of aldosterone is that you secrete, one of the processes for getting more potassium into the cell is secreting getting more sodium into the cell is to secrete excess potassium. And it does that into the filtrate, which becomes urine. So you urinate more of your potassium, so you become relatively hypokalemic. And that's one there. So pheochromocytoma is a kind of rare tumor affecting the adrenal glands. You're going to look for other symptoms around that, so headaches, sweating, flushing, labile or kind of unstable blood pressures are the kind of other clues that this may be a pheochromocytoma. Cushing's syndrome, raised urinary cortisol is potentially going to see that. Thyroid dysfunctions, it's always worth doing a thyroid function check as part of your screen when you've got somebody with hypertension. Obstructive sleep apnea can increase, can cause hypertension. That's a secondary cause. And then, of course, there's always the iatrogenic and drug-induced forms. We know that we can get hypertension from the progesterone-only pill and the combined oral contraceptive pills. Sometimes NSAIDs can cause hypertension, steroids, and of course the illicit drugs. We need to get this social history from our patients, don't we? Because cocaine, particularly, gonna put up your blood pressure. So if these patients are taking that, then clearly some lifestyle advice rather than perhaps putting them on blood pressure medication is the best treatment. But again, that's for you and your patient to decide. So how are we going to diagnose? We've said we're going to look for those secondary causes. I should note that these PowerPoint slides will be uploaded as PDF on our website. So if you want to make notes, or if you want to have these for reference, particularly the flow charts for diagnosing hypertension and starting first and second line treatments may be useful. So for diagnosing hypertension, what do we need? So there's some basics to consider here. We're going to check blood pressure bilaterally. We're going to do it generally on the brachial artery, aren't we? And that's a good reason not to. We're going to check it bilaterally. You always use the higher reading. If you've got significant difference in the differentials, then do consider secondary referral into cardiology to try and establish why we've got such a differential. Obviously, we're thinking about peripheral artery pathologies. We're thinking about potentially aneurysms, aren't we, in situations where there's big differences between brachial artery blood pressures. So what we talk about clinic blood pressures, when I had that explained to me, so clinic blood pressure isn't necessarily like in the ambulance. It's not the first blood pressure that the machine reads, although we should be doing them manually, shouldn't we, really, for accuracy. But if the first blood pressure we read, if that's high, fine, we repeat it towards the end of the session with the patient, whether it be 5-10 minutes later. If that's still high, then we take a third, and then we take the lowest of those second two blood pressures, and that's our clinic blood pressure. So if they're hypertensive, we don't take the first reading. It's going to be the second or third reading we're going to take. And first stage management, if their blood pressure's over 140/90, then then we're thinking that they might have hypertension. We need to confirm that diagnosis by either ambulatory blood pressure monitoring or home blood pressure monitoring. Obviously, the latter being favoured at the moment with COVID, and I dare say will be here to stay. So encouraging the patients where they're able to purchase their own blood pressure monitors and take their blood pressure twice, morning and evening. And keep a diary for you. You want to do that over 7 to 14 days, typically, according to NICE. So I just see the chat's getting busy. So, oh, fine, sorry, yep. So ambulatory blood pressure monitoring. Sorry, let me just keep the chat open so I don't miss anything. So, absolutely. So blood pressure, if your clinic blood pressure is 140/90 or above, then we're going to look at ambulatory blood pressure monitoring. So that's fitting a 24-hour blood pressure monitor. We're going to be doing home blood pressure monitoring more likely at the moment for 7 to 14 days, depending on how severely hypertensive they are. Clearly, somebody that's edging towards that severe hypertension, you can see that below 180 or 120, then we're going to be thinking about bringing them back sooner than 14 days, certainly. So looking for the blood pressure diary, you're looking for any kind of major differences between your clinic blood pressure and what the patient's recording at home. There will, of course, be some difference, and white coat syndrome being one of those reasons. But during that time, we need to do some further investigation. We're interested in whether there's any other organ damage, so target organ damage. We'll look into what specifically we're looking for in a minute. And also we're going to calculate their cardiovascular risk. So we use QRisk3, isn't it? There's a website for QRisk3, which is very user-friendly. Put in all the information and it comes out with their 10-year cardiovascular risk score. And if it's over 10%, then we tend to lean towards medicating these patients a bit more readily, and obviously looking for other causes. So always consider your secondary causes. The list from the previous slides, you're always going to look at reasons why they might have secondary hypertension. But realistically, if you're once you're satisfied that this is essential hypertension, then this is the kind of initial agreed treatment option according to NICE. Ambulatory or home blood pressure monitoring for 7 to 14 days. Review them at the end of that in clinic. And during that time, investigate your target organ damage and calculate the cardiovascular risk. So obviously then we have to deal with severe hypertension, because sometimes we do have patients present with very, very high blood pressure, and we don't know how long that's been necessarily, whether it's rapid onset. So rapid onset of severe hypertension is known as malignant hypertension, and we do need to control that. Clearly those patients are at significant risk of target organ damage and bleeds and so on and so forth. So if you do find somebody with severe hypertension in clinic, then rather than, kind of taking your time over investigating the target organ damage, doing it within that 7 to 14 days that they're away doing their blood pressure diary, you're probably going to do that if you can same day. We'll show you the types of things you're looking for. And you definitely want to see them back at around 7 days. The blood pressure diary has to be about 7 days for it to be meaningful. That's why we don't bring these people back any sooner. But if you've got any suspicion or you find any target organ damage, then you are going to start your medication immediately. You're not going to wait for that home blood pressure monitoring diary to come back to you in a week's time. You're going to start the medication in the meantime and just check that there is a downward trend over that 7 days. And of course, you're going to keep the patient under review for longer, but this is kind of the initial management phase. So retinal hemorrhage and papilledema, that does suggest malignant hypertension. And so these are two reasons why you would need to seek secondary help. And locally, we send to the ambulatory emergency care unit at our local general hospitals. So they will accept anyone with malignant hypertension or symptomatic hypertension that's newly diagnosed. And they would go to the ambulatory care to be seen by our colleagues in secondary care. So by symptomatic, I mean confusion, chest pain, symptoms of heart failure or an acute kidney injury. Then of course they're going to go into AECU. There may be some other process locally, but generally speaking, it's an ambulatory care or equivalent service offered by the general hospital. So fantastic. So that is kind of the diagnostic criteria. So what do we mean by investigating target organ damage? What are we looking for? We're looking at an ECG. We're looking for signs of hypertrophy. We're looking for signs of strain, particularly within the left ventricle. Chronic hypertension is potentially going to cause those. You certainly may see the strain patterns with malignant hypertension. Renal electrolytes, we're looking for kidney damage. Kidneys are very, they do come off poorly if hypertension isn't managed. So we need to look at the renal function. We need to look at the glomerular flow rate. We need to look at how they're managing creatinine and the electrolytes. They need to know how we're doing with the albumin-creatinine ratio in the urine. So ideally for the diagnosis of whether or not this patient also has concurrent CKD. We're also going to do a bit of a screen for other risk factors. HbA1c and lipid profile would be useful. Patients that are undiagnosed hypertension often, not always, turn out to have undiagnosed hyperlipidemia or undiagnosed type 2 diabetes, as we know. They all kind of come together, don't they? And then we're going to do some fundoscopy. So again, it's going to depend on how urgently you want these results. If the patient's severely hypertensive, we're looking to do this same day or ASAP, really, aren't we? And if your surgery has a facility to do all of this in-house, if not, then if it's just this kind of standard hypertension pathway we're following, then we're going to do this at some stage during that 7 to 14 days. Fundoscopy, we're looking for retinopathy and papilledema, which papilledema certainly takes a bit of practice in spotting, doesn't it? I don't think fundoscopy comes naturally to anyone. It's certainly something you have to practice, probably like a lot of things that we take for granted nowadays. Fantastic. So stages of hypertension, just so we're kind of aware of where we sit ourselves. There are 3 stages. Ooh, my laptop's gone to sleep. There we go. So stage 1 is a clinic blood pressure between 140/90 and 159/99. It's either or, the systolic or diastolic. So if you've got somebody with you've got somebody with blood pressure of 150/89, that's still stage 1 hypertension if that's their clinic blood pressure. Likewise, if you have 139/100, still that'd be stage 2, wouldn't it? So over 99, that's stage 1. So it's either or both, obviously. So clinic blood pressure, as I say, best of 3 typically of their hypertension, isn't it? So stage 2 is that blood pressure between 160/100 up to what we declined as severe hypertension. We have 179/119, and then of course equal to or over 180/120 is that severe or malignant potentially hypertension. Where we're going to potentially start treatment immediately, bring everything forward if we can, and maybe seek secondary care advice if we're showing any symptoms or anything's found. Hopefully that's making sense. So they're the stages: 140/90 to 159/99, 160/100 to 179/119, 180/120 and above, being stage 3 or severe hypertension, as is known. So there are some, like all drugs, there are indications, aren't there, for giving antihypertensives. Realistically, there are 2 that NICE give, and that's any age of patient with persistent stage 2 hypertension, but we just need to have in the back of our mind, so severely frailty, I think that's been spelt wrong, isn't it? Frailty, that should say. So severe frailty and or polymorbid patients, then we do need to be aware of side effects of blood pressure medication being exacerbated. So potentially with the severely frail, we're looking at postural hypotension. With the polymorbid patients, we're looking at interactions with other drugs that may be a little bit unpredictable. That being said, BNF is normally a pretty good resource, isn't it, for checking our interactions with other medications, and these patients, potentially maybe on lots. And patients under 80 with persistent stage 1, you notice that over 80 you're allowed to have stage 1 hypertension. That's kind of permissive hypertension. That's for the reasons above, predominantly to prevent postural hypotension and falls, particularly in the severely frail elderly population. So adults under 80, we reduce that threshold to persistent stage 1 hypertension, so blood pressure over 140/90, with one or more of the following. So target organ damage, so if we notice an abnormal ECG with hypertrophy, if we're noticing CKD, if we're noticing fundal changes, or if we're noticing any established cardiovascular disease. So by that they mean things like history of CVA-TIA, heart attacks, angina, and peripheral artery disease. If you already have those established processes, then you're indicated to start them on medication. As with renal disease, so if we've got some CKD going on, if they're diabetic or if their Q risk is over 10, then we are going to start them on antihypertensives at stage 1. Okay, so under 80, stage 1, provided they have one of those risk factors, and often they do. So what's the other option? So, just one little kind of extra point to mention. Adults under 40 that present with hypertension, it's more often than in the older population anyway. It's going to be a secondary cause. So it's worth just getting specialist opinion if you're unsure there. It's worth referral into secondary care if you've got somebody that's particularly hypertensive in a young population, unless they've got loads of comorbid factors. If they're otherwise fit and healthy, do think secondary causes more so than you would with the older population. So good. So treatment aims, we're looking to reduce blood pressures in the under 80s to below 135/85. We're looking at the over 80s to bring it to 145/85. So normotensive in the under 80s, and stage 1 hypertension is permissible in the over 80s. That's the treatment aims. Obviously, if your patients aren't indicated for pharmacological management, but this also goes alongside, doesn't just because then they are having pharmacological management doesn't mean we don't consider the non-pharmacological options. But for those group of patients, so under 80 with stage 1 hypertension but no other risk factors, we shouldn't be medicating them straight off the bat. We should be trying some non-pharmacological options. Hopefully no surprises as to what they are. This is a useful list to have to hand. Increasing exercise if that's a problem. Restriction of salt, again, if that's a problem. If they're not having excess salt, then we don't want to put them on a zero salt diet. That's bad for them. Weight loss, if that's an option. If they're overweight, then clearly weight loss is going to be very useful in reducing blood pressure. A combination of all of these is really what we're looking for. Smoking cessation, if that's an ongoing issue. Alcohol reduction, again, there's mixed beliefs, isn't there? Potentially alcohol in moderation is good for the cardiovascular system, depending on which studies you read. I like to believe those ones, so some bias there. I'm going to go with alcohol helps and gin and tonic cures COVID. That's my theory. High potassium diet, there's some evidence that a high potassium diet can reduce blood pressure, and lipid management, of course. Initially at this stage, because we're talking non-pharmacological, we're talking about reducing red meat within the diet, reducing trans fats, etc. But of course, these patients may present with hyperlipidemia, and you may want to start them on a statin, and actually that may be the only pharmacotherapy that you start. So fantastic. So non-pharmacological options, always worth considering. And even if you are, straight off the bat medicating these patients, it's not going to hurt, is it, for them to lose some weight, do some more exercise, and change their diet if they are some of the contributing factors to their hypertension. So here we go. We get to the nuts of it now, and I think this is what I wish I knew, or wish I had better access to when I first started. Because trying to make head and tail of the nice guidelines when you first read them can be a little bit difficult. So we need to know a few things about our patients before we start them on medication, don't we? First thing. So this is first line treatment of somebody who's got stage 1 or persistent stage 1 or stage 2 hypertension that's indicated for treatment. Although technically this is still the same pathway you're going to follow for those severely hypertensive patients that you want to start medicating immediately. This is your first line. This is the drug that you're going to pick first, okay? And there is some notes there to go through afterwards. So the first thing you want to know about your patient is, are they type 2 diabetic, okay? So the background behind this, as you'll see that all of the type 2 diabetic groups, or both type 2 groups, end up at an ACE inhibitor or an ARB. That's because they do have some kind of renal protection elements to them, and we know that patients with diabetes often have renal failure, renal problems, at least renal nephropathy. And actually the ACEs and ARBs offer some element of protection to the kidneys. So that is why with diabetics, we're going down that line. You'll also see the question there of, are they Black African or Afro-Caribbean? That is because, and for reasons unknown as far as I can ascertain, I did have a good look around for any information as to why, but Black African and Afro-Caribbean descendants respond better to calcium channel blockers than they do ACEs and ARBs. But as you'll see, if you have to go down the ACE-ARB routes, they respond better to ARBs than ACE inhibitors. And as I say, I couldn't find any particularly good evidence as to why. Just lots of trials proving that it's true. So, but nobody really understands the processes. So, broadly speaking, we're looking at putting Black Afro-Caribbeans onto CCBs, calcium channel blockers, unless they're diabetic. Lovely. So this is stage 1. We want to know if our patient's diabetic. If they are they Black? If they are, ARBs. If they're not, we're going down ACE inhibitors. Okay, so we want this renal protection. If they're not diabetic, then a lot depends on age. So are they Black again? If they are, they need to go onto calcium channel blockers because they respond better to those. If they're not, then we're going to look at age. So the younger patients are going to go onto the ACEs and ARBs. So an ACE inhibitor first line in this case, and over 55s, we're going to be putting them onto a calcium channel blocker. So some notes here. So we start with ACE inhibitors. So in the populations other than Black African and Black Afro-Caribbean, we're going to start on ACE inhibitors. But if they're not tolerated, common side effects of ACE inhibitors are the cough. You get the ramipril cough. Then we change to an angiotensin receptor blocker, an ARB. Obviously that's first line, as I said, for the Black African, Black Afro-Caribbean community. So we never give, or we in primary care never give ACE inhibitor and ARBs together. That's not to say that cardiology can't do that, but that's a never together for us in primary care. So it's ACE inhibitor or angiotensin receptor blocker. As you'll see, they work quite similarly. So if calcium channel blockers aren't tolerated, and the common side effects of CCBs are ankle swelling, okay, so they you'll see in a minute that they act on the smooth muscle, they cause vasodilation, and particularly in the older population, vasodilation can exacerbate some underlying mild heart failure, and you can get peripheral edema forming as a result. So if CCBs aren't tolerated, stop that and switch to a thiazide-like diuretic. So the most common one in the UK is indapamide. And that would be the thiazide-like drug of choice. So it used to be bendoflumethazides, so that's gone out of fashion. So we don't use thiazide diuretics anymore. We use thiazide-like diuretics. So indapamide is the only one I've really seen used. If there is evidence of heart failure, then we offer the thiazide-like diuretic instead of or in addition to the first line option. That's just to try and get rid of that fluid. So again, calcium channel blockers don't work particularly well, are often contraindicated in heart failure because they can exacerbate the effects of that, particularly the peripheral edema aspect of it through the vasodilation. So calcium channel blockers in heart failure don't go well together. So we're looking at thiazide-like diuretics in that group of patients. That's not to say that you can't. So if your patient's gone down the ACE inhibitor route, absolutely, an ACE inhibitor and a thiazide-like diuretic together is completely allowed, as we'll see in stage 2. Good. So stage 2, then, if that doesn't work, obviously you're going to monitor your patients, particularly the ACE inhibitors and ARBs. You're going to be keeping an eye on renal function. You want to bring those patients back absolute maximum 4 weeks after starting an ACE inhibitor and ARB. You want to bring them back for Usinase as a minimum, just to make sure you're not knocking off glomerular filtration rate. You're obviously affecting pathology of the nephron, and if you affect the nephron and actually you've got some underlying kidney disease, then we're going to cause problems. As you remember from one of the early slides, if you've got renal artery stenosis and you start something on an ACE inhibitor or an ARB, you may see a rapid increase in creatinine. So that's why we like to bring those patients back for routine bloods. And of course, we're going to keep check of their blood pressure as well, aren't we? Because realistically, we don't want to overcorrect blood pressure. We want to know that we've got the dose right. So over the next couple of weeks, you're probably going to keep in touch, or at least speak to the patients a couple of weeks after you've started them on these new meds, see what their blood pressure is doing, and see how their kidney function is doing. So calcium channel blockers, there's less concern, but again, it's worth checking up with them, make sure they're not getting any side effects, and of course, checking that we've got the dose right. Good. So your second line obviously depends on what they're on first line, doesn't it? So we've got 3 options now. If they're on, what are they on now? ACE inhibitor or an ARB, it doesn't matter. We're just going to add in a calcium channel blocker or a thiazide-like diuretic. Okay. So if you've got a patient with heart failure, you're going to skip the calcium channel blocker and we're going to go for a thiazide-like diuretic in Damaye. So ACE inhibitor, for instance, perindopril, that's being tolerated, or if it's not, we've switched to candesartan, for example, for an ARB. They've got heart failure, we'll whack them on thiazide-like diuretic instead of calcium channel blocker. But if they're otherwise fitting well, we'll pop in some amlodipine or licidipine or something. If they're already on a calcium channel blocker, they're over 55, not diabetic, and then we are going to ask the usual question: are they Black African or Afro-Caribbean? If they are, then obviously our first line choice is going to be an angiotensin receptor blocker. If they're not, then ACE inhibitor. Or again, you have the option of the thiazide-like diuretic. If they, particularly if they've got some heart failure, they probably shouldn't be on the calcium channel blocker. But particularly if they're getting any side effects, whether you put the thiazide-like in with the calcium channel blocker is obviously down to a bit of clinical discretion. You're probably going to put it instead. But calcium channel blocker, you're going to add either the ARB or the ACE inhibitor, or you can put in a thiazide-like diuretic in addition. So in those patients, so as I say, the Black African and Afro-Caribbean responding better to the ARBs. ACE inhibitors, if they're not tolerated, you're by all means able to put the rest of the population on an ARB. So thiazide-like diuretics, if they're already on that because calcium channel blockers weren't tolerated, for example, again, the usual question, then we're going to put them on an ACE inhibitor or an ARB, depending on their ethnicity. And that's obviously if they are on the thiazide-like diuretic, it's because the calcium channel blocker wasn't tolerated. So that's why we don't see calcium channel blocker on this list here. So it's an ACE or an ARB. And anecdotally, anyway, ACE inhibitors and thiazide-like diuretics work very well together. We tend to see very good control of blood pressure and also peripheral edema in those patients that have heart failure. They seem to be a good combination. Good. So stage 3 is triple therapy for regardless of what patient you've got there. This is triple therapy, but of course, being careful in those patients that have heart failure, you may not necessarily want to start calcium channel blocker. That may be a group of patients you refer into secondary care. So ACE inhibitor or an ARB if not tolerated, or if in the ethnic groups that respond better to ARBs, plus a CCB, plus a thiazide-like diuretic, as I say, just with that caveat of careful with heart failure and calcium channel blockers in often is a contraindication. And again, secondary care opinion may be sensible in these patients if we're moving them to triple therapy or thinking we need to. And then, of course, there is stage 4. Stage 4, you're now really asking yourself, hang on a minute, have we missed anything? Are they taking the medication properly? Compliance? Is there something we're missing here? Have they got secondary hypertension? Is there something else going on? Always ask yourself that anyway. But if you are starting to think about putting somebody on a 4th antihypertensive, we need to know their potassium, because realistically what we do depends on potassium. If the potassium's low normal, then we can go for a potassium sparing diuretic such as spironolactone. In fact, that's pretty much the only one we use. If their potassium is high normal, then we're not going to spare any potassium. We don't want to make this patient hyperkalemic because we can cause cardiac arrhythmias. It goes without saying, if you're looking at spironolactone, you're definitely going to be keeping a close eye on renal monitoring. Until such time as we can establish that the patient is stable on that new dose. So big kind of caveat of watch their renal function, watch their electrolytes if you're putting them on spironolactone. Again, these patients are not well. If they're on 4th stage antihypertensives, a lot of the usual stuff hasn't worked. So potassium over 4.5 millimoles, we can consider, whoopsie daisy, we can consider an alpha blocker or a beta blocker. And we'll look at the difference between the two and whether we have any particular guidance. Anecdotally, we tend to put more people on alpha blockers than beta blockers. It does just seem to be because they're more effective and don't cause so much issue around the heart. And don't forget, a lot of these patients are going to have an element of heart failure. We don't want anything that's potentially going to worsen that, although you'll see they do cause vasodilation in the same way that calcium channel blockers do. So if we're starting 4th line, we definitely need to be alert to the idea of postural hypotension, definitely with spironolactone adding a second diuretic. So you have a thiazide-like and a potassium-sparing diuretic. So we definitely got to be alert to the idea of postural hypertension, and that's the case certainly with the alpha and beta blockers. Careful monitoring of electrolytes and renal function, absolutely. That goes without saying. And refer to cardiology if hypertension remains uncontrolled, or if you have any, if just generally, if you're not, this patient is not settling down and we can't really figure out why. That's when cardiology come involved. There is no 5th stage for primary care, but this is managing your patient to the highest level of primary care's ability, really. And often these patients are going to end up with a referral around this time if we're still not managing them. At the end of the day, they're sick, aren't they? They're going to have more than just essential hypertension going on. There's lots of other problems you're going to find if you dig deep enough, more than likely. Good. They're the 4 stages. Hopefully they're useful. As I say, the PDFs of this presentation will be up online. Hopefully you can find that useful in clinic. Certainly putting this together has made my life a lot easier for when I start patients off and things like that. So let's look at some of the medications. So spotting the meds. So it's the end of the words, isn't it? So the prils are the ACE inhibitors. So I've highlighted the ones we commonly use. So each CCG or primary care network through their pharmacists will have kind of a preferred blood pressure. There is so much choice and there's so little difference between them. In most cases, there are some that stand out. But each primary care network will have its preferred drug, and right now at the moment in our local area in East Berkshire we prescribe perindopril first line typically. That's not to say that we can't use lisinopril, ramipril, captopril, any of them. I'm sure if you get hold of them, I'm sure we could prescribe those and nobody will bat an eyelid. But that's the kind of preferred one in our surgery at the moment. So perindopril for ACE inhibitors. How do they work? Well, going back to this diagram here. So ACE inhibitors are, let me just get rid of that box. ACE inhibitors come into force here. So we know that renin is produced in the juxtaglomerular cells. That breaks angiotensinogen from the liver down to angiotensin 1. And it's ACE that converts angiotensin 1 to angiotensin 2. If you take out ACE, you don't get angiotensin 2, right? Nice and easy. If you don't have angiotensin 2, you also don't have aldosterone. Okay, so there's a little bit of a caveat here. So angiotensin 2, if it's not produced, sorry, you also don't get any of the others. So if there's no angiotensin 2, you don't get antidiuretic hormone because nothing stimulates the posterior pituitary gland to produce antidiuretic hormone. You also don't get aldosterone because it doesn't bind with the angiotensin receptors in the adrenal cortex. You also don't get that element of vasoconstriction caused by the angiotensin 2 directly. You also don't get that raise in increased sodium reabsorption in the proximal convoluted tubules. So net effect, nothing happens to blood pressure, does it? Neither of these two come along, so none of this stuff happens in the kidney. Nothing changes. There are some effects of angiotensin 1 if you want to study at the bio kind of cellular level. The angiotensin 1 does do things, but angiotensin 2 is the main driver for increasing blood pressure. And if it's not there, none of this other stuff happens. So ACE inhibitors, nice and simple. They are renally protective. They offer some protection to the nephron through the way they work, and as such, very, very good for diabetic patients and for the younger patients that are often going to develop comorbidities because they're hypertensive young. So that's why they tend to go onto the ACE inhibitors. But as I say, common side effects, and we do get it a lot, is that they give patients a cough. Okay, so not all patients can have ACE inhibitors. So then we pop them onto angiotensin receptor blockers, and of course we pop the Black African and Afro-Caribbean community directly onto ARBs because evidence suggests they do better. So they're the sartans, anything that ending in sartan. So again, highlighted in blue is the one we prefer, which is candesartan, but I know losartan is very popular. As is irbesartan, you see that quite often. But candesartan is our drug of choice in the angiotensin receptor blockers. Where do they work? They work in the adrenal cortex. So they work on the angiotensin receptor blockers of the adrenal cortex. That means angiotensin 2 is still in circulation. Okay, we don't stop angiotensin converting enzyme with an ARB. That's only an ACE inhibitor will do that. So angiotensin 2 is still in circulation, and angiotensin 2 causes smooth muscle contraction. It also stimulates release of antidiuretic hormone, but it doesn't release aldosterone, and aldosterone is the most effective of all of these pathways. Angiotensin 2 itself does increase sodium reabsorption. It does cause systemic vascular resistance to increase. It does cause antidiuretic hormone, which in turn increases water absorption in the collecting ducts. So you are going to still have a bit of a rise in blood pressure from angiotensin 2, but you're going to lose the big effect of aldosterone. Okay, aldosterone is not going to increase sodium reabsorption in distal convoluted tubules and collecting ducts, and this is a big net effect that we're losing. That is why they are effective. So angiotensin receptor blockers work on the angiotensin receptors of the adrenal cortex. To a certain extent, there is some evidence to a certain extent that they do slow the release of antidiuretic hormone, and they do slightly negate the effect of systemic vascular contraction, but mostly we're affecting this pathway here. So we're losing aldosterone and we're losing this sodium reabsorption in the DCT and collecting ducts. Okay, so calcium channel blockers. So our first line for the older non-diabetic population and of course Black African and Afro-Caribbeans of all ages without diabetes, calcium channel blockers are our first line. So again, amlodipine is still our first line. That being said, lasodipine is commonly used by our surgery as well. One of the partners certainly recommends that as being less causative of peripheral edema, it does seem, and to be fair, when we've had patients on lasodipine, they've generally complained less of peripheral edema than patients on amlodipine. Certainly, we've switched patients from amlodipine to lasodipine, and they've seen a reduction in peripheral edema. Whether there's anything more than a bit of luck going on there, I don't know. But amlodipine is still the kind of number one go-to calcium channel blocker that we see. But there are others. Nifedipine and felodipine are also commonly used. I've certainly seen them out and about. How do calcium channel blockers work? Basically, there are two predominant types. So you have the dihydropyridine calcium channel blockers, the DHP channel blockers, which work selectively on the systemic vascular resistance. Okay, so they increase. Sorry, they increase smooth muscle constriction within the arteries and the arterioles. So if we have vasoconstriction, we increase systemic vascular resistance. And no, sorry, scrap what I just said. Let me get my teeth in and my head in gear. So calcium channel blockers work on the smooth muscle cells of the systemic vasculature. And they reduce, they release, they cause vasodilation. Okay, by causing vasodilation, you reduce your diastolic blood pressure. But this is where you get the side effect of peripheral edema from, because you're starting to, in some ways, but there's some theory that if you're causing a relative vasodilation, you're also going to cause capillary leakiness, etc., and you're going to get peripheral edema at the lower limbs. And it does happen. It's a fairly common side effect of calcium channel blockers. So the dihydropyridine the DHP calcium channel blockers work generally just on the smooth muscle of the vasculature. What we have is the non-DHP, and if we flick back to that list there, so the non-DHP ones being diltiazem and verapamil, they don't just work on the smooth muscle, they also work on the calcium channels within the cardiac myocytes. And they reduce heart rate, they reduce contractility. Okay, not great in heart failure, but very, very good if your patient has a high baseline heart rate. So patients with AF, a non-DHP calcium channel blocker is an ideal selection. And certainly we see diltiazem used in patients with atrial fibrillation. Again, not great with heart failure. So if you have concurrent AF and heart failure, not a great combo. We can look at other ways of managing those, and we'll talk about that in the AF session. But diltiazem and verapamil used where you want to bring down the patient's baseline heart rates, because they work on the calcium channel blockers within the heart as well. But the DHP ones do not so much anyway. There's a little bit of overspill, there always is. Fab. So one up in the chats. Yeah, licidipine, yeah, it reduces peripheral edema. We use it in our surgery. Absolutely, yeah. There's a, as I say, there's a partner in our surgery that swears by it, and he prescribes it first line pretty much for most patients, and actually with good results. So there must be some reason why licidipine is less associated with that than amlodipine and the other CCBs. Good. So verapamil and diltiazem, just bearing in mind, they work in slightly different ways. They have much more overspill onto the calcium channel blockers within the myocytes, reducing heart rate and contractility. Not great in heart failure, but very good in AF. Fab. Okay. Yeah, perfect. Yes, yeah, it definitely does work. Calcium channel blockers are very good if tolerated. Okay, fine. So alpha blockers and beta blockers we're going to talk about. So these are your fourth line medications. We've skipped past thiazide-like diuretics because realistically it's just indapamide. That is the thiazide-like diuretic, and the potassium sparing of choice is spironolactone. We don't use bendoyl-flumethazide anymore, but patients that are on bendoyl-flumethazide, there's no reason to take them off if they're tolerating it well. So that's that. Good. And so the alpha blockers are the SINs generally. So doxazosin is our first line. Don't forget, we use alpha blockers for other reasons other than hypertension. Tamsulosin particularly because it's not very cardioselective. Alpha, it's an alpha blocker that works very well on enlarged prostates, as most of us will know. So tamsulosin is an alpha blocker, but very little effect on blood pressure, hence why it's used in that case. But it's still within this class of drug. Doxazosin is I think pretty much the only one of those that I've seen used as an alpha blocker. You also have the option of beta blockers, and there are loads. Bisoprolol is of course the go-to. And we'll have a look at that. Obviously, the net side effect with bisoprolol more than the alpha blockers is a reduction in heart rate again. So useful in AF and are used in AF even if the patient isn't necessarily hypertensive, as we'll see in the AF lecture. Also see atenolol. Atenolol is popular. Bisoprolol is our surgery's drug of choice. And nebivolol. Nebivolol, there's a cardiology professor locally that is quite frequently sending patients back to us on nebivolol when they don't tolerate bisoprolol, when they get postural hypotension and things like that from bisoprolol. So nebivolol seems to be becoming quite popular. I've certainly seen a few patients change to that recently, but any of the beta blockers. I put propranolol on the list because it is a beta blocker, but we don't use it for blood pressure monitoring because it's pretty useless at that. It is good though at causing vasodilation and in the brain, which is linked to migraine prophylaxis. So when we talk about the neuro and differentiating headaches and treating headaches, we'll talk about propranolol in a bit more detail and why it's a very good beta blocker for migraine prophylaxis. Good. So bisoprolol, the beta blocker of choice. Lovely. Thank you, Sonia. Perfect. So just popping some drug names in there. Good. So how do they work? Alpha and beta blockers work on the adrenoreceptors. So alpha 1 adrenoreceptors occur within the systemic vascular. They occur all over the body, but predominantly the alpha blockers that we're using, the cardioselective alpha blockers, are going to affect the systemic vasculature. Again, we're going to cause vasodilation. They're going to blockade the adrenoreceptors. So when the sympathetic nervous system sends its signals down, it is going to blockade that and stop the vasoconstriction ordered by the sympathetic nervous system. Beta blockers, so beta 1 receptors in the heart, beta 2 receptors in the lungs. Just bearing in mind that's relevant because all beta blockers have some element of overspill, even in the most cardioselective for beta 1 receptor antagonists. They do have some overspill into beta 2 receptors, and of course beta 2 receptors can trigger asthma. So we don't particularly want to give beta blockers to asthmatic patients, or if we do, we're going to be kind of keeping an eye on their symptoms, aren't we? Had a similar conversation recently with starting migraine prophylaxis for an asthma patient. How is propranolol going to be tolerated? And thankfully was tolerated well. So beta 1 receptors in the heart, they predominantly deal with rate. With an element of contractility, which is ordered by, again, we're affecting the signals from the sympathetic nervous system by blockading the beta 1 receptors. Sympathetic nervous system asks for an increase in heart rate and increase in contractility, we block it. With beta 2, obviously we're affecting the lungs, we're causing bronchoconstriction, which isn't a good thing, but there is always a small element of that, although probably asymptomatic in any patient that's not asthmatic. Fab. See if there's any questions coming up. Yeah, propranolol for anxiety as well. Absolutely. Yes. Yeah, it's a very common one for anxiety. It seems to be a very good drug for those types of things. So beta 1 in the heart, beta 2 in the lungs. There's 1 heart, 2 lungs. Alpha 1 receptor in the systemic vasculature and responding to sympathetic nervous system instructions to cause vasoconstriction and blockade of that. So that's kind of how we are working. So a bit of a case study to finish off with then. Sorry, it's gone on a little bit. These things always do, those of you that have watched in the past. We always kind of try and finish with some kind of case study or something to make it a little bit more interactive to see what's gone on. So, oh, why is this not working now? So here we go. 60-year-old female presents to the clinic, with a clinic blood pressure of 165/99. She's not known to be diabetic and she is white British. So if we go to menti.com and pop in the code 8752619, let's have a vote. What is the correct initial treatment plan for this lady? So 6-year-old female with a blood pressure of clinic blood pressure 165/99. She's not known to be diabetic and she is white British. What is the correct first-line treatment for this lady? So go to menti.com, 8752619, and tell me what you're going to do first. So don't pop it in the chat, pop it on menti.com, have a little vote. So let's let some of you vote there. Are we going to, A, start a calcium channel blocker and monitor her use and needs closely? Are we going to send her away for home blood pressure monitoring, investigate target organ damage, review in clinic with the results? Are we going to start CCB, home blood pressure monitoring, and offer lifestyle advice? Are we going to start an ACE inhibitor, ARB, depending on which is tolerated, and monitor use and needs closely? Which answer is it, A, B, C, or D? So her blood pressure is 165/99. She's not known to be diabetic and she's white British. Oops, what's happened there? Oh, goodness me, what on earth has happened? Sorry, computer's having a moment. Fabulous. So let's just see how we're getting on. So lots of votes coming in, good. So some of you saying start CCB and monitor use needs closely. Lots of you saying home blood pressure monitoring, investigating target organ damage, reviewing in clinic with the results. Some of you saying starting CCB with home blood pressure monitoring and lifestyle advice, and starting an ACE inhibitor, ARB, and monitoring use needs closely, also popular. Okay, let's let just a few more of you have a chance to vote. So this is your initial actions. So a lady presenting with stage 2 hypertension. She's 60, white British, and non-diabetic. So absolutely, most of you getting that right there. So the first thing to do is start her on some home blood pressure monitoring, either 7 to 14 days. During that time, investigate some target, whether there is any target organ damage, and then you review her in the clinic with those results. Okay. Let's come back to the case study then. So the next step is, so she comes back, she's done her average home blood pressure monitoring. and her average home blood pressure monitoring reading over that week, you've sent her away for a week because it's reasonably high. You don't want to leave her too long like that. It's 162 over 95. So we're happy that we're in stage 2 hypertension. Her ECG is normal sinus rhythm. She has normal U's and glomerular filtration rates. Her HbA1c is 39, confirming that she's not diabetic, and her lipids are up a little bit. So that might be a discussion to have. So those are the kind of target organ points of mention. Let me just bring back the Mentimeter, and in theory, bear with me a sec, folks. Something's gone wrong with Mentimeter. Shock horror. So there we go. So go back to menti.com. So same code 8752619. Which of the following would be a suitable first-line treatment? So it's drug names. This time you've got a choice of ramipril, losartan, doxazosin, or lasitipine. Which would be the best one to start her on? Nice, easy one to finish off with. So lady with stage 2 hypertension, she is indicated for pharmacotherapy. We are going to, so she's got no signs of target organ damage, and her blood pressure is confirmed that she's stage 2 hypertensive, white, and not diabetic. What would we like to offer her? I'll let a few of you vote there. Fantastic. There we go. So let's see where everyone's going. 64% saying ramipril, 7% saying losartan, nobody's saying doxazosin, and 31% saying lasitipine. Okay. So it's a 60-year-old white British lady that's not diabetic with stage 2 hypertension. She should, of course, have a calcium channel blocker. The only calcium channel blocker there is lasitipine. So well done to the 30% of you that's got that right. So fantastic. We'll come back there. And that brings tonight's episode to a close. I apologize we've run over a little bit, but I hope it's been useful to you. Before you disappear off, I would say I'd be really, really thankful if you've enjoyed tonight, that you do like us on Facebook, share our posts, and if you've got time to leave us a review, we'd be most grateful. Trustpilot, Facebook, or Google reviews. If you can leave us a review to say you've enjoyed tonight's webinar, that would be amazing. If you would like your certificate, I'm just going to double check with Charlotte whether she's been able to locate the link for our chat. So let me just have a little look. Oh, fantastic. Thank you, Charlotte. She's put it in there. There is a link just gone up in the chat. Click on that now before it disappears halfway up the chat with everyone saying thank you. Have a little look at that. So if you register there, click on that link. You'll have to just leave a little bit of feedback. That's only seen by us. And then it should let you download a PDF certificate to say you've been along tonight. So just click on that link now before it disappears. The recording, yes, absolutely, will be recorded. We have recorded it. It's going to go up on YouTube. I'll put a link in the events section of Facebook. Okay, so like us on Facebook and you'll get a notification when that happens. Yes, absolutely, everyone will be recorded, Kirsty. So next week we are talking about heart failure. We've mentioned it tonight anyway. So that will be recorded, absolutely. So webinars at stctrainingsolutions.co.uk if you have any questions or want to suggest future content. But if you want a certificate, then you need to go through that link that's in the chat. That will also be on our Facebook page. If you don't get it now, you can do it later. I hope it's been useful. If this is something you want us to continue, then obviously we'll absolutely do that. It's really good. So we'll be back next Monday at 7 o'clock again. In the meantime, I hope you'll stay safe. And if there are any questions, folks, please do send them over now. If you think of something later on, feel free to tweet us or drop it into the chat, our email, webinars@stc. Training Solutions. You're more than welcome, everyone. I hope it's been useful. It sounds like lots of you have found it useful, which is brilliant. Excellent. So yeah, there's the link in the chat for your certificates. You're welcome, everyone. Have a good evening. Stay safe, and hopefully see you next Monday. Fab. So if there's no questions, I will pause the recording.